So I'm here to talk about endovascular treatment of the common femoral artery, which otherwise known as the final frontier. To disclose, I am a vascular surgeon, so when I first got this topic, I thought, no, I just really don't think that's reasonable, but some of the research I've done into this actually slightly changed my mind. Like I said, I have no disclosures. So endovascular therapy, as we are all really aware of, in the last 20-some years has really increased fourfold. It's lowered morbidity and mortality to vascular disease, and this has generalized a endo-first approach to most peripheral arterial disease. With the advent of newer therapies, such as drug-eluting balloons, drug-eluting stents, atherectomy, I foresee that this frontier is going to be pushed further and further. Common femoral lesions, as well as lesions within the profunda, have really been the last holdout for open surgical therapy. And part of the reasons for this is that they're really well tolerated procedures. And they have relatively low morbidity and mortality, but I'll get back to that in just a second. The other stronghold is that it's a very durable surgery. It's, as you can see, I'll show you some data on the long-term outcomes. And again, bifurcation disease into the profunda, we're able to treat part of the external iliac, the common femoral SFA, as well as profunda disease. And historically, there's always been a concern for stent fracture and compromising future surgical options if you have to stent across the profunda or stent across the common femoral. So the question becomes, truth or fiction, is common femoral endarterectomy a benign procedure? So recently, there's been more papers publishing about what exactly is the morbidity related to common femoral endarterectomy. And overall, it's not a completely benign procedure. It is a surgical procedure. Most of the papers report about 0 to 3.6% major complications, meaning return to OR, massive hemorrhage. The vascular VQI itself reviewed about 1,500 cases and found overall mortality to be about 1.5%. The risks they noted were increased in patients with COPD, steroid use, obesity, diabetes, most of which are related to patients who have problems healing wounds. However, then the question becomes, well, why do we keep doing it? Well, the outcomes in long-term patency is excellent. 90 to 100% primary patency at 1 to 5 years with a limb salvage rate of 85 plus. Majority of the secondary interventions are to treat disease above or below the target lesion. And as we heard this morning, the increase in hybrid procedures has really decreased that in cases of common femoral endarterectomy plus iliac or SFA stenting. So then what about endovascular therapy? The papers currently out there show about a major mortality and major complications at about 1.6%, which is relatively the same as common femoral endarterectomy. Where endovascular therapy really exceeds open surgery is the rate of minor complications, 5 to 8%, and usually these are related to the access, dissection, perforation, and in patients who underwent atherectomy, distal embolization is always a problem. There's definitely a shorter length of hospital stay, 1.5 days versus 3 days for a common femoral endarterectomy. So then why do we not do it for all patients? Well, the outcomes are slightly problematic. Across the board, going back to about early 2000s, the restenosis rate and reintervention rates range anywhere between 20 to 30%. Target lesion revascularization, 20%. 1 year patency, not bad, 88%, but obviously lower than open revascularization. And within the vascular VQI, reintervention rate for survival, 85%. And they found that stent use increased the risk for reintervention and amputation. So we needed more data, and that brings me to the TECCO study. And this is it was kind of lauded as a big study, and everybody got very excited about it. It was a randomized prospective study looking at surgery versus endovascular therapy in 2017. What they found was that there was an increased perioperative morbidity in open surgery, so 26% versus about 12.5%, with really no difference in long-term outcomes. And they concluded that there was a significant benefit of stenting over surgery, or endovascular therapy over surgery. From the vascular surgery perspective, there were a couple of problems with this paper. The surgery itself was not uniform, so they considered multiple different interventions within their surgery arm, including bypasses, which is an interposition graft within the common femoral artery, at 20%. And I think if you ask any vascular surgeon, interposition grafting is really a very different animal than common femoral endarterectomy. And we don't go into a case thinking we're going to do an endarterectomy and then switching over to a graft. It's a different animal. The majority of the complications were minor, and you can kind of discuss what is a minor issue with your patient and yourself, but delayed wound healing was one of them. Not an infection, but just after 30 days, the skin was not closed. Paresthesias requiring drug use, and local infection, which is a major problem with open surgery, but obviously these are you're not going to see with percutaneous access. The patency in their common femoral endarterectomy arm was much lower than the overall reported, 82%, as you can see, in comparison to some of the other data I've shown. 4 patients did require open conversion at the time of stenting, and 1 patient in the stenting group required major amputation, but he wasn't included in the outcomes because the stent at the time was patent. So this is something that definitely needs further clarification. So then what does this mean for the future? More data is needed. We really need to look at the overall population, standardized reporting, and do more randomized controlled trials. Dr. Zeller has talked to us about what's up and coming, and I think that may give us some answers. In my opinion, common femoral artery is still gold standard. It's high durability, low risk. However, I think, we mentioned a lot about it during this conference, that we have to use all of our tools in our toolbox. Concurrent therapy, not exclusive therapies. So therefore, patient selection is going to be key. There's increased risk, we know, for open operations in patients with COPD, diabetes, steroid use, obesity. I was throw in there patients who have radiated groins or reoperative groins. If you've ever done one of those, let me tell you, we really, really don't want to. However, there's probably also a patient population that's at increased risk for endovascular therapy, such as patients who are younger, who are going to be followed up for 20, 30 years. And patients who may need further revascularization down the future. If you jail the profunda and you have loss of bypass inflow, that is a major problem. And newer therapies need to be included in all of this. Atherectomy, drug-eluting stents, drug-eluting balloons. And then really to tier out which lesions are amenable to endovascular therapy. Is it the heavily calcified lesions, long lesions, or is it the focal, smooth lesions that we see? So things to think about for endovascular therapy. I will give you the caveat is when I do see common femoral disease, I tend to prefer to do open endarterectomy. So some of these are from the various papers we've looked at and sort of the general consensus of things. I think number 1, surgery should always be considered. You should have a discussion with the vascular surgeon or your interventionalist to say what is the right therapy for the right patient. The goal really should be to preserve the common femoral anatomy, and that really means to preserve the profunda flow. Angioplasty, use a balloon size that's matched to the native vessel. This decreases your risk for dissection. If a stent is needed, the lowest number of stents needed, bare metal, again, really to preserve the profunda flow. And the really take home is that these patients need to be followed up. It's very important. These are not people that we can see a month post-op and send them on their way. We know these patients have a propensity to need higher rates of reintervention, so they need to be looked at, they need to be investigated with non-invasive imaging or CT scans. I always tend to take the pessimistic view in life and in general. What can go wrong and how bad would it be to fix? And then on top of all of this, we need to remember vascular disease is a whole body disease. We need to treat these patients well from an antiplatelet therapy, statin therapy, and obviously smoking cessation. Thank you.